Hello, everyone, and welcome to the 2021 Zada Cooper Leadership Seminar. My name is Lupe, and I am honored to be your MC for today. I would like to ask everyone to join me in turning on your cameras if you are able to do so. I'm a fourth-year pharmacy student, and in fact, will be graduating next week. So I would like to give a shout out to my graduating class of 2021. So if everyone can give an applause for them. Thanks. And as one of the recipients of the Zada Cooper Leadership Award last year, this seminar holds a very, very special place in my heart, as well as does the committee who put together such an amazing lineup of speakers for all of us today. And to help me thank these individuals, I would like to pass on the microphone to one of the best Toastmasters that there is at our college. And if he is in line already, is Dean Tender in yet? Maybe that wasn't 30 seconds, Barb.
Hi, Lupe. How are you?
There we go. Yes.
Good.
Did you hear me, Dean Tender?
Yes, I can. I can hear and I can see all 58 of you that are on the call right now. So that's a wonderful thing. And Barb, thanks for sending me the connection. I got an invitation with no Zoom connection. So I'm glad we got all of the those little snafus taken care of. It's so good to see so many friends. Well, all friends, but it's just good to see so many of you, some of whom I haven't seen for quite some time, for sure. I'll tell you, I am delighted to be part of this program. You know, I still harken back, if you'll just indulge me for just a moment, I still harken back to this luncheon meeting I had with Melissa Corrigan, I don't know how many years ago it was right now, when we sat at 126 downtown and we started talking about Zada. And out of that conversation then grew a small subcommittee, and out of that grew this and a number of other things where we celebrate Zada's life and women's leadership. So I always harken back to that, and I hope somewhere along the line that is captured in the history of this program. Shoot, I could go right down the line here, and I see Sandra, I see Helen, Gretchen. I mean, I could keep going right on down the line here. Nancy, my goodness gracious, all of the folks that have been such a part of this program in times past. So it's nice to see all of you and welcome here today. We're just, despite this virtual format, we're no less enthused as we would be if we were all in person. It is my great pleasure and honor to introduce to you Metalou Henderson. And I actually got to meet Metalou in times past, but quite honestly, it's been quite some time since I've had a chance to see her. Metalou, thank you so much for being here today. I know you're quite the historian, but just a little bit of background on Metalou. I don't know if she got hives when she moved to Ohio, but all of her education was Arizona. I mean, I don't know. She, you know, master's, bachelor's, master's, PhD, and then somehow she found her way to Ohio. I guess the same thing could be said about this East Coast kid finding his way to Iowa as well. But she all of her background educationally. And I actually got to know her when she became associate dean at Ohio Northern and oversaw student affairs there. But over the course of time, she's become quite prolific in her writings and, of course, has written about women's leadership. And she actually dedicated time writing about Zada Cooper. So with that, I'm going to turn things over to Metalou. Meta, I thank you so much for being a part of our program here today. And why don't you take it away, and then we can get on with our presentations. But Meta, share with us a few thoughts about Zada Cooper, please.
Thank you so much. Zada Mary Cooper graduated from the University of Iowa with a 2-year pharmacy diploma in 1897. She immediately joined the faculty and retired from there in 1942. She was very involved in pharmacy and organizations immediately. She mentored male and female students and encouraged pharmacists to be more active. Although one of a few women faculty members nationwide, she was encouraged to attend meetings and become active in national organizations. In 1912, she attended both the APHA meeting and was the first woman to attend the American Conference on Pharmaceutical Faculties meeting, which is now, of course, AACP. She was one of the petitioners to establish the women's section of APHA and became a member of many of the ACPE committees, including those on activities of students and alumni. The need for an organization for women pharmacy students was very apparent, and the need to encourage females to become pharmacists. Zada Cooper was the person working between the women's section of APHA and ACPE to establish such an organization, Kappa Epsilon. She worked with Dr. Rufus Lyman on this. Along with Dr. Lyman, she is responsible for the founding of the Rho Chi Society to honor academic achievement of pharmacy students in 1922. There was to be no discrimination based on sex, race, or religion. Very unusual for that era. She is called the mother of Rho Chi. She was named secretary of AACP in 1922 and served until 1942, the only employee. She has influenced women students, women pharmacists, women faculty members, and women active in pharmacy organizations. She always worked with men to accomplish so many of her projects. In fact, I was told if whatever Zada wanted, Zada got. She wrote extensively on pharmacy issues and, of course, women pharmacists. She was active in so many aspects of pharmacy and pharmacy education. She died in 1961 at the age of 86 in the 25th anniversary issue of the American Journal of Pharmaceutical Education, which was dedicated to her. She was called the Grand and Glorious Lady of Pharmacy. Kappa Epsilon was founded in 1921, delayed by the pandemic of the Spanish flu. This year, KE celebrates 100 years with activities delayed because of this pandemic. Thank you.
Thank you, Metalou, and yes, thank you very much. Thank you very much. I'm going to turn things back over to Lupe, Metalou, once again, thank you so much for being with us. And as you were speaking, I had a chance to flip the pages here and see so many friends, and I wish I could be with all of you today and in person, but that's not possible. But just know that seeing your faces on the screen means so much. So thank you so much for being a part of today's program and celebrating Zada and celebrating women's leadership. We're most grateful. Lupe, take it away, please.
Thank you, Dean Latender. Indeed, Metalou, thank you for your passion for research in the history of women in pharmacy. I want to invite our listeners today to check out episode 17 on Melissa RX scripts. I really enjoyed learning more about Zada and how she never took no as an answer. So if it wasn't for you, we wouldn't know her as well as we do her. Thank you so much. Now, another woman who seldomly takes no for an answer is our first speaker of the evening/afternoon. She is the president of the American Pharmacists Association and executive vice president of Tabula Rasa Healthcare. I introduced myself to her during the 2019 APHA meeting in Seattle, and I don't regret it. She is already a great mentor to me, and I look forward to the innovative work that she continues to build and that we learn from her. So with another round of applause, please help me welcome Dr. Sandra Leal.
Well, thank you so much, Lupe, for the introduction, and thank you all for the opportunity to be here and speak today. This topic I will be speaking about is so personal to me because of basically my entire career and my life and what I've experienced, which is equity. And so I'm really happy to talk, but let me share my screen here. I wanted to thank Dr. Latender for the invitation, Melissa, Barbara, everybody who helped coordinate this event. And I wanted to start by sharing a picture here. Some of my favorite people, but Meta-Lu, I just thank you, Meta-Lu, for being here and introducing. Meta-Lu lives right down the street from me, and we took this picture. I don't know if you remember Meta-Lu, but about 2 years ago, I remember it was Valentine's Day because we went out for lunch that day. And so I have the pleasure of living in Tucson and sitting and going to lunch with Meta-Lu, hopefully more frequent now that the pandemic is hopefully resolving, but we've been able to go to lunch several times a year. And I always love to hear the stories and everything that she shares with us about history and all of her work that she's done for the profession. And the other picture I have here, I have Lupe, who was, as she mentioned, we met in 2019. And so we've been connected now for several years now, which is great. This was a picture of the women pharmacy presidents, and we invite a mentee to meet. And so this was a great opportunity to meet. Unfortunately, we couldn't do it together at the annual meeting, but at least we were able to get together and talk with the group. And so I love the fact that we have this opportunity to still collaborate and mentor. So I wanted to thank the both of you for starting off the presentation here. As I was reflecting on Zada Cooper, one of the quotes that really struck me about her, I went to the website and read a little bit about her, but was this quote, and it stood out to me. So let me read it to you. She wrote in 1914, "Neither man or woman alone can remedy the existing evils and improve conditions single-handed. We need to be members of our professional organizations, and perhaps they need us." And so I think a lot about what she wrote here so long ago, and I really think about the importance it is of us to be active and to take a significant role in changing conditions that we don't agree with. So to the point that she doesn't take no for an answer, that's been definitely something that's guided my career. It's always been about mission and trying to make better things happen for people, especially those that have been disproportionately impacted, those that are underserved. And I always figured that if we can crack that nut on the people that have the most challenges, we can definitely help everybody else. So I thought about the theme here, health equity. It all begins with you, because it really takes us to be champions in anything that we really care about for us to make a difference. So I definitely, in order to know me, maybe my explanation of where I grew up will help you understand why I feel so strongly about equity. But I grew up down in Nogales, Arizona, and this is a picture of Arizona. So right here where the arrow is pointing Santa Cruz County, I grew up on Nogales, in Nogales. There's a Nogales, Arizona, and then there's a Nogales, Sonora. So this is a city that essentially continues through the border. And I'm in Tucson, Arizona right now in Pima County. So I still live about an hour north of the border. My mother still lives down in that area. And so that area really impacts everything about me growing up. My parents are actually immigrants from Sonora, the state right there that you see south of Arizona. And so I lived basically up and down that border for a long time. And so the border is defined as the area north and south of the border, about 62 miles north and south. And there's this region there that's really impacted by health issues. There are 44 US counties in this area, and then 26 federally recognized indigenous tribes. I happen to work with one, and I'll be sharing a little bit about my experience and why it's so important to me. But if the border were a separate state, here's how it would rank as far as disparities. It is last in access to healthcare, second in deaths due to hepatitis, third in deaths related to diabetes, first in school children living with poverty, and last in per capita income. And one of the areas that I focused on a lot in my career was in diabetes. And I actually really cared a lot about this condition because it impacted my family so personally and my community so personally. So that is one of the areas that I felt I could really impact because of the need for having people that spoke in the language of the populations that we've worked with, and then just the need to serve people that really didn't have access to care. But just as an additional note of the area, unemployment in that area is very high, almost 2 to 3 times higher than the average in the US. And then 37 to 45 of the areas, those counties, are health professional shortage areas. And this will come to be very important, because I will talk a little bit at the end about the provider status bill that we're trying to pass for the profession in medically underserved areas. But prevalent conditions, I already mentioned diabetes, but heart disease, tumors, cerebral vascular diseases, chronic liver diseases, cirrhosis, pneumonia, and influenza. And now definitely COVID, we're seeing a lot of the people in that region significantly and disproportionately impacted by these conditions. And so this is a great picture that sort of describes the concept of equity and some of the conditions where people live. We have, if you look at the left, there's a lot of inequities or worse health outcomes if you have things that don't contribute to good outcomes. So for example, adverse living conditions, occupational hazards, discrimination, unemployment, then you are likely to have worse health outcomes. If you have better conditions, if you have quality schools, quality housing, quality environment, health insurance, then the chances of you having better outcomes are much, much greater. So how do we get the tree on the left to grow and to be more lush, essentially, and have better outcomes? That's essentially what I think about and how I think about being able to contribute. So a picture of me growing up, this is me in the middle here with my dad and my grandfather. Growing up, it was incredible. A lot of the family that I grew up with had diabetes. And unfortunately, my father had diabetes, type 2 diabetes growing up. And I remember it was so striking to me, but a lot of my dad's family members that lived in Mexico didn't have access to any care whatsoever. So unfortunately, they died very young and with very significant complications associated with diabetes. So it was sort of traumatizing to me to see, my 40-year-old aunt and uncles dying because they had foot ulcers and because they had so many significant conditions that could have been managed had they had the information, the access, options and treatment. And so that really influenced me to say, what can I do about it? How can I change this situation? And so that immediately set me off on a path to try to do something in healthcare. I didn't know what at the time, but that was something that I definitely had an inkling to do. So why did I choose pharmacy? So I chose pharmacy because I ended up really going into Mexico, and the pharmacists, the pharmacies in Mexico were my point of care. We would go into the pharmacies there. We would be able to access and answer our questions. And that it was because we couldn't really reach other providers in the area, and especially not providers that spoke the language that my family spoke, which was Spanish. So a lot of our community members would essentially go to Mexico to reach their healthcare. Now, my first job in high school was as a community health promoter, so what we call a promotora de salud, which was a health promoter. So I was in high school and I became a health promoter, and I worked at a federally qualified health center. So my first job was down in Nogales at Mariposa Community Health Center, and they actually were able to provide a scholarship for me. It was a scholarship to become a healthcare provider. And so that was a significant investment in my life, because it ended up, again, giving me that path of going into healthcare and to help to support me when I really didn't even know I was going to go to college at that time. But I knew in 11th grade, that's when I decided I was going to be a pharmacist. So it didn't take long to decide on pharmacy because I had so much interest about it. So this is me at the University of Colorado. That's where I went to pharmacy school. I was able to receive a scholarship to go there. And this is my father and my mother and my younger brother. And I remember how incredible this experience was. In fact, my mom was really nervous about me going away to college, and especially going out of state. But I told her, I have to go because I needed the scholarship. And this was an opportunity that I couldn't pass. But in Colorado, this was a great experience because they really taught me about the roles pharmacists can play in ambulatory care settings, and really exposed me to a lot of the models that I brought back to Arizona, to Tucson, and implemented at the practice that I ended up with. And so this is a picture that I love, and I reflect on it all the time. Do unto others as you would have them do unto you. My father was a very golden rule kind of guy. He was just very much about giving back to the community. And if you could help others, mentor others, give others opportunity, that was what you needed to do. So that was how he taught me. And so I think a lot about the work that federally qualified health centers do. And so one of the aspects about federally qualified health centers, and the reason I bring this up is because after I came back from Colorado, I ended up doing a residency at the VA. And then one of my first positions, and my position for a long time, was at El Rio Community Health Center in Tucson, Arizona. I worked at the federally qualified health center there for 14 years, which is essentially related to the Mariposa Community Health Center, where I first had my job. And I feel like that exposure in high school and then the work that FQHCs do is tremendous. One of the aspects that I love the most about federally qualified health centers is that they represent the patients that you serve. So part of the governing board of FQHCs requires that at least 51% of the board members are members of the health center, that they're actually patients of the health center, and that they represent the community that they're served. So if there's any quality improvement or anything like that, the consumer members or the patient members are able to influence that. So I worked at El Rio for 14 years until I joined Symphonia, which is now part of Tabula Rasa Healthcare. But one thing that always brings me back to FQHCs, and I want to share with you, is that I just, about a year and a half ago, I joined the board of El Rio Health Center. So somehow I keep coming back to that FQHC model just because of the impact that they have in the community. And it's interesting to be on this side of it now. Now I'm actually a patient of the health center, and I'm sitting as a patient representative and then sharing, my experience there and what we can do to contribute and have better outcomes. So a little bit about the experience in the local example, and still why I see such a need for what we do, and definitely the role of pharmacy. This is an example of one of the indigenous tribes that I mentioned earlier. This is a tribe that we worked with at El Rio Health Center, the Pascuayaqui tribe. It's literally about 10 minutes from my home right now. But one of the things that we see in working with this population is just the disparities that still exist, even though we live here in the same city. This is the life expectancy of some of the populations. And I always remember how striking it was to me to see the differences in life expectancy. So if we look at the average life expectancy of the average United States citizen, it's between 72 up to 78. But what we see in some of these indigenous tribes and in Alaska Natives is something much, much lower than that, 57, 58 years of age. And that hasn't changed much in 2020, 2021. In fact, we're actually seeing life expectancy rates decrease instead of increase. So I always remember thinking about this number and looking at it and saying, I can't even believe that just 10 minutes, down the street from me, we have this 20 to 30 age difference in how people live or don't live because of the differences in their conditions. So this really spoke to me. And so one of the areas that we really focused on was trying to develop programs specifically with diabetes management, where the pharmacist was embedded in the care team, really trying to do that. And that was one thing that really led me to work and to continue to try to contribute to the FQHC. So this is my father. I mentioned him earlier, but unfortunately, my dad was one of these examples. Unfortunately, my father died at the age of 58. And I think about his experiences and what happened. He was a farm worker when he first came to the United States. He struggled with diabetes. And it was actually when I was in Colorado, when I first truly understood that he had diabetes. And I'll never forget this story, because I remember when I left home, my mom said, your dad's really missing you. He's lost a lot of weight and he's just not the same. And so I thought he did. I thought he was really missing me, and he was. But when he came out to visit me in Colorado, he was really sick. He came, I saw him, I'm like, Dad, you look sick. We went to a health center up in Colorado. And I remember his A1C was 13% when he was diagnosed. And he had diabetes for a number of years. So he had experienced the same issues that a lot of people face, where he didn't realize he had diabetes. He had a pretty aggressive presentation, and unfortunately he passed away. So I all of the work that I do is really personal to me because of what happened to him. And so a lot of what I do now is really to try to figure out how I can contribute to his legacy, because every opportunity I've had has been as a result of being able to become a pharmacist, having the education, having the opportunities, being able to contribute. And so it's a personal thing to me to make sure that his name And everything he's done is something about giving back to, to the profession, and then giving back to others that struggle and have the same types of situations. And during this pandemic, we've seen that the experience with COVID has been tremendously disproportionately affecting populations like Hispanics, Blacks, American Indians. You see conditions that are just, they're not fair. They don't seem to get better, but how can we make things better? The Navajo Nation, for example, has been one that has been disproportionately affected by COVID. If you look at why this happens, you look at the percent of running water in people's homes. Only 1 in 3 homes have, access to things, simple things like water, electricity, local grocery stores. So basic infrastructure isn't there. And this is just up the street from me, up in northern Arizona. At one point, they were worse than any part in the world. And we had some terrible areas. We had Italy and Spain that had tremendously bad outcomes. But right here up the street, we had this same situation presented with the Navajo Nation. Factors that affect, health include social and economic factors, which I already mentioned. But the things that we definitely need to contribute are things like, shelter, education, food, income. And so how do we do this? This isn't a presentation about what's wrong, but this is a presentation about what we can do to change these conditions. So, one of the things that I wanted to talk about is, how do you contribute? So some of the things that Zada Cooper has done is really create things like mentorship programs, leadership opportunities, things that actually start changing the experience and the opportunities. And 2 of the experiences that have really led my path have been joining groups like the Association of Clinicians for the Underserved and the National Center for Farm Worker Health. In both of these groups, I was the first pharmacist board member to be able to sit in those groups and really share the experiences that pharmacists bring to the table. And for both of these groups, I was the first president of the organization that was a pharmacist. And so I know that the experience of sharing with other providers and other members of these groups have shared experiences about what we can contribute to the team and how we can make situations better, especially for those people that need help the most. So there's been a lot of talk recently about systemic racism in public health. The American Pharmacists Association in the last year stood up a task force to address structural racism and look at some of these conditions that impact people disproportionately. And so I saw this graphic and it really spoke to me, but why is this happening? What are the stressors, the chronic stress that are impacting people in a negative way? And when we look at things like hypertension, diabetes, obesity, maternal mortality, we see much, much higher presentations in people that experience that disproportional stress, and things like, access to care. I was reflecting this morning as I was getting ready to present, just even my own experience growing up. I remember being a pharmacy resident and not having health insurance, and actually being in pharmacy school and not having health insurance. And at one point I got really sick in pharmacy school. I thought I was having appendicitis. And I called my parents and I said, hey, do we have health insurance? It's kind of funny, but it wasn't funny because I really needed it. I didn't want to have this huge bill. And my dad said, no, we don't have health insurance right now. So I remember I didn't go to the doctor. I went to sleep. I got up the next day. I was fine. But those were things that I had to think about a lot of times as I was trying to figure out my own situation. And here I am in a health professional program. And here I am, a pharmacy resident, and I didn't have health insurance. So when I sat there at El Rio and I sat there and listened to people's situations, and they don't have health insurance, or they have these very high deductibles, or when they have issues affording their medications, that's when I feel like I need to activate and do something to try to figure out a different alternative for people so that they don't have that added stress. So I really think about how it all starts with one person. What is that one thing you can do, and what is that situation that you can help impact? And a lot of times it's about advocacy, it's about collaboration, it's about joining your professional organizations, it's about joining a task force, something that you can do to try to change the situations for those that are less able to achieve whatever they want to achieve. I was very happy to see that in early April, the CDC actually talked about racism as a public health issue. And they started this website, Racism in Health, where there's actual tools to start helping clinicians to start helping address some of these issues. I just wanted to mention this as a resource and tool because we would need hours and hours to talk about the potential opportunities that they're out there, but it's steps like these that really start making a difference because we're acknowledging that there's a problem and that we need to do something about it to make sure that we start addressing the conditions that exist. Really, I mentioned that it starts with health equity starts with you, but it really starts with us. It starts with all of us starting to understand that something needs to happen to change so that things are more fair. We talk a lot about equality and it sounds fair, but this graphic is great. You can have equality, it sounds fair, but really what we need to look at is more the equity. And how do we look at different populations that are struggling and how do we make it so that those populations that have more barriers have, in this case, more stepping stones so that they can reach and so that everybody has parity. Because after equity, you have justice. And what we really need is justice so that we have people having better situations. So I wanted to thank Zada Cooper because really what she gave me is a lot of opportunity. When I think about this picture, I wanted to thank Zada Cooper, who started the women's section of the American Pharmacists Association in 1912. I'm standing on the wall here. This is a wall of presidents at the American Pharmacists Association boardroom. And when I walk in there, it's an incredible room. I remember walking in there and looking around and there were walls and walls of pictures. I thought maybe one day my picture will go up there. There are 155 men and only 10 women in that wall right now. I will be the 11th woman, which is incredible, but I feel it's women like Zada Cooper that started the path and gave us opportunity to be part of APHA that make a difference. And all of the 10 other women presidents who have come before me, the incredible work, incredible roles that they've played to create that opportunity for me. I hope that you, Lupe, one day are on that wall also because of the opportunities that you're having and some of the great mentors that you're having there. I also wanted to mention Rho Chi. When I was in Colorado, I was inducted into Rho Chi, and just last Friday, I was asked to be the speaker at the Rho Chi induction ceremony in Colorado. So it's incredible to me that something that Zada Cooper started 1922, I think is when she started this, to both be inducted and then to be able to present at Rho Chi is just an incredible testament to her lasting legacy and what she's been able to contribute to the profession. So I hope that, again, I have that opportunity to give something back as she's given, because this is such a great forum that we've built around her name and all of the incredible impact that she's made for the profession. So these are the other very incredible women in my life. This is my mom's mom, my own mother in the center, and then my daughter. So many women that contribute to my success and to making me want to think about improving the situation for other women. But truly, I take a little bit from all of them. And I hope that my daughter is also very mission driven. We talk a lot about the goals, the dreams, and what to do, how to be service oriented and how to give back a little bit. So, I look at them and they're definitely the future and the past of everything that is me. So I'm going to end with that. Be like Zada, be the voice. That was my my theme for the APHA meeting this year. Hopefully you had an opportunity to listen to it. But essentially, my goal was to really talk about being the voice for any issue that you have, to speak your mind, even though it's uncomfortable, to make a change, to advocate for the right things, to contribute back. Because if you speak up for those that have challenges, I think that, it's very rewarding if you see those challenges be overcome. So I feel like Zada was doing that many, many years ago. Hopefully we can contribute to being able to give back and to make sure that things change in a positive way. I have this last picture. It reminds me of the one I showed earlier, which is about, it was Norman Rockwell, the Golden Rule. This is an artist, Kadir Nelson, who painted this picture, and I actually have it as my desktop picture on my computer. It's called Sew Together, because I mentioned equity starts with you, equity starts with us, but together we make it even more, we make it even better, and we actually start representing the populations that we really have here in the United States. So this picture, I think it's beautiful, and it's very representative of things that I want to see. And I have the last thing that I mentioned I was going to talk about, which was I would be terrible if I didn't mention this, but the provider status for pharmacists, which is something that we've been fighting for so many years. I know a lot of you who are on this call today have actually done so much work to try to get this across the line here. But we just introduced APHA on April 22nd, the federal provider status recognition for us to be added as eligible providers to the Medicare Part B Social Security Act. And it's really targeting pharmacy and medically underserved areas. And so it's in the House and it's in the Senate. And we want to make sure that we have the opportunity to get this passed, because it would really start addressing a lot of the things I talked about, making that change that we need to make so that people have more access to pharmacists as a standard of care, and not as just, a best practice, but is always part of the care team. This is a start. It's not the finish. We started with medically underserved as our way to get our foot in the door, but our goal is really for this to become the standard across anything we do. So an action item, if you have an opportunity, is to go to the link here, write a letter. It will go to both the House and the Senate, and we're trying to collect as much support, not just from pharmacists, but from other groups, so that it shows that we have support from healthcare providers, from patients, from anybody who's willing to sign. So thank you so much for the opportunity to be here. Thank you for the invitation. I hope that you've learned a little bit more about where I come from and why I tick, and it's really to try to make a difference in others. But again, thank you so much.
Thank you, Dr. Leal. Everyone, our virtual applause, please. And thank you for all the tools that you shared with us today. They are being shared on the chat box, so please feel free to copy those before we close the meeting today.
Lupe, I don't want to leave anybody out, but I just wanted to point out that on this call, there are at least two other past presidents of APHA, Bob Osterhaus and his son, Matt, and wanted to acknowledge that. And if there are any others, forgive me, but I can't go through all of the faces here. And we also have, in terms of women's leadership, Lisa Gershom, who's on the call, and past president of ASHP. So a lot of firepower on this call here today. And I'm likely passed over someone, and I apologize, but I just wanted to make note of the fact that we have other senior leaders on this call, and wanted to acknowledge that at all, as well as just say, Sandra, you knocked it out of the park. Thank you.
Now, I'd also like to welcome any questions that our audience has. We do have a couple minutes that gives us some time for a conversation. If anyone has a burning.
I just, pardon me, Lupe, I'm sorry, but Nancy Alvarez, and I said hello to her at the beginning, but I forgot about Nancy too. So you got, hi Nancy, and so nice to see you as well. So I'm glad, thank you. That was my slip up, because I said hello to Nancy at the beginning, and she too is a past president of APHA. So wonderful. Lupe, I'm sorry to interrupt, but I just wanted to acknowledge those folks. Back to you.
That's okay, no worries. Now, the best way probably to go about any questions that the audience has will probably be to use the raise your hand function. But if you are not sure how to use that, feel free to just unmute yourself. I'm sure not everyone will jump out at once. If you can't think of any questions now, I will be sharing a link at the end of the meeting where you will be able to submit any questions to Dr. Leal, and she'll be able to answer those at another time. So if it's all right with everyone, not missing any hands raised, we'll go ahead and keep on with the program. So Dr. Reese, please take it away.
Thank you, Lupe, and congratulations on your upcoming graduation and future plans in residency. We're very proud of you. Hello, everyone. I'm Jeff Reist, and I'm a clinical associate professor here at the College of Pharmacy. And it is my great pleasure to introduce my longtime friend and pharmacy school classmate, Helen Eddy, as our next speaker. Helen and I go way back. We're both graduates of this program from 1982. She graduated from here and then later earned her MBA from Drake. She has over 30 years of leadership success in the healthcare industry and has extensive skills and experience in organizational planning and building relationships. Helen was instrumental in initiating the Iowa Healthiest State Initiative and served as its first executive director. 3 years ago, she embarked on a new adventure when she accepted the position as the Polk County Health Director. Little did she know that she would serve in that position during a pandemic, and she is now steering Iowans through the COVID-19 pandemic. Helen, I am honored to have known you since our early days in pharmacy and very proud of your many contributions to the improvement of the health of Iowans throughout your career. We look forward to hearing about your leadership journey and the lessons learned in your role as the Polk County Health Director. Welcome, Helen.
Well, thank you, Jeff. And you don't give yourself enough credit, Jeff, because you are actually the reason I'm a pharmacist. I say sometimes I'm kind of an accidental pharmacist. I was a pre-med major when I started at Iowa, and Jeff and I were in classes together, and I really wasn't enjoying my parasitology classes, to be perfectly honest. And we were walking out of a class, and I said, boy, I don't think I can do this for a really extended period of time. And Jeff said, well, maybe you should apply to pharmacy school. And my mother had always said, if I were going to do it over again, I would be like Jim McLuhan down at McLuhan's drugstore in Indianola. And between Jeff and my mother, that was good enough for me. And this week has been very, very bittersweet because after my conversation with Jeff, I walked across the bridge and across the Iowa River and to the College of Pharmacy and had an appointment with Dean David Carew. So his passing is a very bittersweet thing for me because between Jeff's encouragement and Dean Carew's willingness to let someone with not much purpose directly towards pharmacy into pharmacy school, I owe my career to both Jeff and Dean Carew. So I'm very thankful for that. So I'm going to share my screen here and we'll get started. And let's see if I can find my slideshow. Here we go. So my story. So you got the pre-story, and I did graduate from the University of Iowa in 1982 with a BS in pharmacy. And the reason I'm going to tell you this is that I think some people have very, very direct career paths. A lot of people kind of wander through and bump and turn. And my point of telling you this is that there's something to be learned from every chapter of your career that may come back to serve you. So I graduated from Iowa in 1982, and I immediately went to Drake University to get my MBA because I didn't think I wanted to be a retail pharmacist, which is really funny because I ended up spending 30 years at Hy-Vee in retail pharmacy. But at the time, I didn't want to do that. And my mother was someone that said, she was really much, I would describe her as a make lemonade kind of person. And I said, I don't know about this pharmacy stuff. She said, you're going to graduate, you're going to finish, and then let's think about graduate school. And I had started taking classes at Simpson College in my hometown. My mother will tell you it was to keep me out of trouble in the summer. So I would take econ classes, accounting classes, marketing classes, and that rolled into the MBA from Drake. I graduated from Drake and I went to work as a sales representative for Eli Lilly for a period of about 3 years and learned a lot, but learned that really industry wasn't for me. I moved back to Des Moines from the Quad Cities and went to work for Hy-Vee. And again, this is the story where it meanders a little bit. I answered an ad in the paper for a part-time pharmacy job at Hy-Vee because I needed to pay my car payment, and I was still pursuing positions in hospital marketing and other things. And funny thing, joke was on me. The part-time job turned into a 30-year career at Hy-Vee. And in that career, I was in the retail stores directly for about 8 years and spent 22 years in corporate pharmacy management. And when I went into the office in corporate pharmacy management, there was literally myself and one other person. There were two of us that ran all of Hy-Vee's operations. And as those grew, part of my responsibilities in this period of time was really, as the profession of pharmacy was changing, it was really to start to train and implement those kinds of programs in our retail pharmacy offerings at Hy-Vee. So you see some of this here. I developed an immunization program, really worked closely with Drake. We were early adopters at Hy-Vee in terms of flu immunizations, and it's grown. It served us well during this COVID pandemic. We could not get through what we're doing without pharmacists helping us administer the vaccines that we need in our community, but establishing also pharmacist skills training in diabetes, asthma, and other things. That grew into a time in health and wellness where I oversaw, this was Hy-Vee's first position in health and wellness, and I oversaw everything but pharmacy. They kind of moved me from pharmacy to everything but pharmacy. So I had the Hy-Vee dietitians, I had the Hy-Vee health markets, which is all the natural and organic products. I helped develop the 9 healthy Hy-Vee healthy U-mobiles that you see out there. That's pretty funny if you know how non-mechanical I am to think that I helped build 9 Winnebagos. That just is funny. But again, we're using those now in this COVID pandemic. So you never know what you've done and how it will come back to serve you. And then, yes, as Jeff mentioned, in that health and wellness arena, a little initiative was getting launched, and my former chairman and CEO, Rick Juergens, along with John Forsyth from Wellmark, Doug Reichart from Holmes Murphy, and then Governor Branstad, started having these conversations about how we make Iowa the healthiest state. And there's a long story behind it, but I got very involved in that on Hy-Vee's behalf, and then made the decision to create a nonprofit. Again, not something I studied in pharmacy school, I'll say that. And we created the Healthiest State Initiative, and it's still in existence today. I did that for about 4 years, and then I came back to Hy-Vee, and in that I did more health and wellness, and then I oversaw the Hy-Vee Pharmacy Fulfillment Center, which really helped me understand a production line, throughput, and some other things. But I would say during my days at Healthiest State, I left a little bit of my heart in public health. That was really my first exposure to population health and how we really maybe would take a look at the factors that could make a community actually healthier. So as I concluded I was reaching my 30-year mark with Hy-Vee, I really thought, I want to get back and I want to give back to my community. I think that's a common theme that you hear from myself and Sandra, is it's that desire to give back. And so I retired from Hy-Vee, and 1 month later, I started at the Polk County Health Department as the executive director. And yes, while the pandemic was not in my actual career plans, it's kind of what life handed me. So I've had to draw on all of really my experiences throughout my entire career to try to figure out how to serve our community. And what I really want to do is touch on what we have seen here in Polk County in terms of the real effects of health equity and the social determinants of health on the COVID pandemic. And I know you've heard some of this from Sandra, so I'm going to go through it a little quickly, but the definition of health equity is really that opportunity that people have for everyone to be as healthy as possible. And you heard again that there are longstanding systemic health and social inequities that have caused certain groups, minority and ethnic groups, to be at increased risk of illness from all kinds of things, but in this particular context of getting sick and dying from COVID-19. And I always think of, similar to the slide that Sandra showed, that what we really look at is that often we hear about, well, we just need to give everybody the same thing. And if you think about the barriers to that fulfilled life, that fulfilled health, that perfect state of being able to be healthy and being well, that when we give everybody the same thing, there's still barriers and there are people that are left out. The concept of equity is that we give everyone what they need so that they can fully participate and in the game. And call it liberation, call it justice, social justice, but when we get to really where we want to be, there are no barriers whatsoever in our community for people to be able to fully participate and to be healthy. I think of health equity as the umbrella and the goal of where we want to be, but the social determinants of health are the things that are the barriers that keep us from being what we can be. And I'm going to let you read this here, but it really is where people are born, grow, live, work, and age. And I think you saw it on Sandra's presentation, but we always say about 20% of our health and well-being comes from our genetics, and about 80% of it comes from the rest of this stuff. It comes from where we live, work, play, and economic conditions and situations. And these are the social determinants of health. I'm not going to read through all of them, but in public health, we say employment and income are health. Housing is health. Transportation is health. Walkability is health. Literacy, language, education, those are health. Access to food is health. Racism is health. All of these things. And sometimes I think in healthcare, we get real focused over here on the far right, on the healthcare system. But that's only a small piece of the puzzle of what it takes to make someone really, really healthy. And the impacts of all of these are that we get poorer health outcomes. And again, Sandra touched on it, but it is a physiological response. When you are dealing with, how am I going to put a roof over my head? How am I going to feed myself? How am I going to get to my job? How am I going to do all these things? Your body is awash in constant bath of cortisol. And it's that constant stress bath of cortisol in your body that leads to the diabetes, the obesity, the mental health issues, the increased risk of cancer, and all of those things. So it is a physiological response to that chronic stress. This is just another vision of it, but there are a couple of things in this that I like, is that you see that at the center is that goal of being healthy, having equitable communities where our individuals live and play, but there are things that show that on the outside, there are pressures from these biases and these drivers. But the next part is that I think we often forget that these solutions to these issues need to be community driven. We need to engage the community. So in these federally qualified health centers, it's so important that they have members of those health centers sitting on those boards. Too often in healthcare and even in public health, we identify a problem and we think we have the solution, and we never talk to the people that are going to be affected by the programs that we put in place. It's crucial that we engage them. So I'm going to share a little video, and if you haven't seen this, this is from the California Endowment. It's about 4 minutes, but it's a tale of two zip codes. And I think I love this video because it really lays out what happens. And I think you heard Sandra talk about the difference in life expectancies 10 miles down the road. I want you to listen to this, and I want you to understand that this happens in every community across the United States. It happens here in Des Moines, it happens in Iowa City, it happens in Cedar Rapids. So I'm going to play this for you. We'll see if my technological skills are sufficient.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs. They're around the same age. They're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of B-Ville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for deaf kids and easy access to emergency and preventive health care. On the other hand, Beeville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhaust from the nearby highway. And for food options, Maria's only choices are Beeville's many liquor stores, fast food places, or convenience stores. The schools in Beeville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Beeville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening.
I'll stop and pause that there because then it goes into a commercial for the California Endowment. But I think that very clearly lays out why we see these things and what happens. So I'm going to try to see if I can't go to my next screen. Here we go. So with that background, I really want to tell you the COVID-19 story from Polk County and what we have seen throughout this pandemic, because all of this really has fed into what we are seeing on the ground here in Polk County. And I'm going to share some statistics with you of what we have seen. But for us here in Polk County, we started monitoring this little outbreak in China actually back in December and January. We started meeting formally in the middle of January to talk about this virus that was emerging. We started meeting every week. We do this often with viruses, and sometimes they don't amount to anything. They kind of burn themselves out. But we started talking about what a response would look like here at the local level if this was the real deal. And it did turn into the real deal. So we started looking at what would we need to do in terms of contact tracing? How would we structure? How would we organize? And on March 6th, we made the decision to activate our Emergency Operations Center, the EOC. We are lucky to be co-located here in Polk County with our emergency management agency, Polk County EMA. And we have real experts next door that when you talk about a pandemic response, you're really following an incident command structure, which is a formal structure that and a way of communicating that was put in after 9/11. But one of the things that I've learned is that it's a way to organize your planning and your response. And there's a very structured way that communications flow, informations flow. The thing that maybe ought to scare everybody that knows me is that I have a formal role. When it is a public health response, and it's ESF 8, Essential Service Function 8, which is public health, I am the incident commander. And I think that's the title I've been waiting for my whole life, not public health director, but incident commander. I am the boss. I get to say, yes, no, this is what we do. But we activated our Emergency Operations Center on March 9th. And we very quickly realized that part of what we needed to do was gather our major health systems and clinics, because in a pandemic, this was not something that we could do alone, and we had to have a coordinated response. We brought them together on March 12th and pretty much told them that they needed to set aside, our expectation of them was that they were going to set aside their normal competitive nature between Mercy and Unity Point. We brought in Broadlawns, primary health care, and the Iowa Clinic, and said, you need to set that aside for our community. We need to work together, and we need to be able to share information and have a unified response. And the next day they came back and we activated what we called our medical coordination center. I think I probably fibbed to them. I said, oh, we're going to put in like maybe one really long week of, 8 hours a day. I need a decision maker from each of your agencies, and we're going to lay out what this could look like. Well, 1 week turned into we're still at it. So that's what happens. But an example of this kind of work very early on was, could we have a uniform visitor policy across all hospitals in Polk County so that everybody was the same? Testing protocols, they were uniform. Vaccination protocols have been uniform. So there's some real effectiveness to that model. And then during this time, we were waiting for that shoe to drop. And on March 15th, we had our first case detected here in Polk County. We were glad we weren't the first. Sorry, Johnson County, they got to go first. And so, the press wasn't quite so interested in us. It wasn't quite the same big deal, but this started and initiated our contact tracing and interviewing. I have a team of highly trained public health nurses, my communicable disease team, and they started contact tracing, which is really old school. It's called, you call people and you interview them and you try to identify where they've been, who they've been with, and then you interview and talk to those people, and you start the isolation process, quarantine process, and all of that. By about April 13th, we started seeing cases detected in meatpacking plants. While we have only one meatpacking plant here in Polk County, and it's not a large one, we have a very large one right next door to us in Dallas County with the Tyson plant. And we have approximately 500 Polk County residents that commute every day over to that plant. So they contracted it potentially there, but they were living in Polk County. And we started seeing these cases. And as we would do the interviews, we started to pick up that common thread of what was going on. And by 12 days later, it was exponentially out of control. We had an overwhelming number of COVID cases linked to the meat processing plants, and it was overwhelming our system. These were people that did not have the means to socially isolate and quarantine effectively. My back dock, because our job in public health is to take care of them, to get them through their quarantine and isolation. It looked like I was running a grocery store and a diaper store. I had gallons of milk in the refrigerator because we were taking food boxes out to these underserved families to try to help them safely quarantine and isolate through this period. So really, what contributed to this? These are those social determinants of health. They come into play and they show up in your face during a pandemic. We had crowded working conditions with little to no physical separation in those meatpacking plants. There was pressure to work even when they were ill, pressure from the employer, but also pressure from home. If I don't work when I'm ill, I don't have a paycheck, I can't pay my rent, I can't feed my family, I can't do all of these things. So they would go to work ill and spread it in those crowded working conditions. There's also crowded living conditions. Very often it's multi-generational families living in one small apartment, one small house, with really no ability to successfully isolate themselves and not spread that. So we had to try to coach people on how can you isolate this? Can you isolate the person who's sick? Can they sleep in a separate bedroom? Can you at least separate it with a curtain? Can you open a window to improve airflow? All of these things, but those crowded living conditions contributed to the spread of COVID. Travel to and from work. This is how travel happens. Perry is about 45 minutes from Des Moines. So there's usually one guy that has a driver's license and a van, and then he charges the other people $40 a week to take them back and forth to work and back. They would knowingly ride with people that they know were ill. The windows weren't open, no one wore a mask, and they spread it. So these are when we talk about these social determinants of health, these are the real things that happen in people's lives that in a pandemic contribute to that spread. So here's what I want to show you, start showing you the data and what we've seen. And you're going to see some similarity in some maps. This is a map of Des Moines. This is Ankeny and the northern suburbs. I want you to look right here at the core. 50314, 50316, 50319, 50317. It's actually in there, 50320. If you are familiar with Des Moines, this is the urban core. I'm in 50314. I am 5 blocks to the east of Drake University. I'm in the Drake University neighborhood just to the east. This is where we sit in 50314. These are where we had some of the top rates of COVID-19 per 100,000. We look at these per 100,000 because it takes a percentage isn't valid. We want to take population out of it and look at it on an equalized rate. Okay, so those are my top 10 zip codes per 100,000 for COVID-19 in Polk County. This is the social vulnerability index from the CDC. They measure the impact of education and basically say, where are your most socially vulnerable people? Where is their poverty? Where is their lower achievement? Where is their lower income? I want you to look at something. Dark blue is not good. That's higher vulnerability. 50314, 50316, 50309, part of it down here, downtown. Actually, this little corner in 50309 is that we have some low income, high rise apartments. 50320. Do you see a pattern? Here's where we overlay the maps. The reds are the top zip codes. Here's your social vulnerability index. It follows. I will tell you, if you want to follow rates of COVID infection, you follow the poverty and you follow the vulnerability of that community. They go hand in hand. And this just mimics what Sandra showed you. These are the Polk County numbers back in February. And again, disproportionately, our communities of color were affected here in Polk County. They had higher rates per 100,000 of transmission of COVID-19. And then finally, I threw this one in here. This is the old Des Moines red line map. Again, you talk about those systemic things. This was a New Deal era lending program where they came out and drew maps of communities and said, basically to banks, good places to lend are green, bad places to lend and where you should not invest are in red. One of the factors that went into redlining for being designated as a red zone was being a community of color. So D2, D5, right here, it matches those other maps I just showed you. It's the same. Let's add to the fact that in the 60s, some of these for a while were fairly successful. African-American, Black, middle-class neighborhoods. In our development and in our decisions back in the 60s to put I-235 into Des Moines, we put it right through the middle of the neighborhoods that were maybe still thriving. So when you drive through the middle of Des Moines and you drive through on 235, you're driving through what was once a thriving middle-class African-American neighborhood that we didn't want to put the interstate through the other parts of town. We could have put it through to the south. We could have put it someplace else. Nope, we put it right through town. So those are when we talk about systemic racism and old decisions and systemic kinds of decisions that happen. When you have a pandemic, you see the real life consequences of some of these things that have gone on for years. And my challenge always to people, much like Sandra, is be the one. Challenge yourself, get uncomfortable, and ask yourself the questions. Ask yourself, take off the blinders. What's going on in my community and what's going on in my neighborhood? And how can I make a difference? Now, we're into the vaccination stage. These are the vaccination rates in Polk County. And if you go live on our Polk County Health Department website, we update them every Tuesday. You can go by zip code and see what the vaccination rates are. These are my 6 lowest COVID-19 vaccination rates. You're gonna get tired of hearing me say this: 50314, 50316, 50317, 50320. right here in the urban core that has been most disproportionately affected by COVID infection are now the communities that are most resistant to getting vaccinated. In these neighborhoods, as of this week, we're making some progress, but their COVID vaccination percentages are maybe around 40. I have neighborhoods out here in West Des Moines, 50265, where I live. Vaccination rates are nearly 70%. So my work and my team's work is in here. So what's the hesitancy and what's causing the hesitancy? We have a mistrust of government and a history of experimentation. You've heard about the Tuskegee experiments. When you have conversations in the community with people, it very much is a real thing and it weighs on their minds. There's also a mistrust of government from our undocumented workers when we have a vaccine that is being supported and distributed by a government. Are you going to use this as an opportunity to round me up, pick me up, and challenge my immigration status? So we have to communicate that we don't ask for IDs. That's not what this is. Anyone may have a vaccine free of charge. Again, that undocumented status. Religious beliefs. We are a very, very diverse community here in Des Moines, and we have a variety of religious beliefs, and some of those religious beliefs increase some of the vaccine hesitancy. There's historical trauma. They've had some horrible things happen at the hands of government, and they're very hesitant to take it. Language barriers. When we set up a clinic, we always want to know, do you need an interpreter? Our website is available in English and Spanish, and we have a language line available because we have 100+ languages that are being spoken here in Des Moines, Iowa, and in Polk County, and we need to be able to serve every person that we see and that comes through our doors. A lot of misinformation out there on social media, and there are different social media channels that and people that different communities follow. So you have to identify those and work with those trusted leaders in those communities to combat that misinformation. The fear of a chip that can track you being injected along with the vaccine is a real thing in these communities. And while that may seem a stretch to some of us, it's not a stretch at all for them. And we need to be respectful of that. Transportation barriers. Again, how do I get to a vaccine location? Do I have even computer access? Do I know how to make an appointment? Do I have internet access? Luckily here in Des Moines, our mass transit system will give anybody a free ride on DART to a vaccination site. For some other folks, we are giving free taxi rides. We have access to Uber and Lyft that, again, we can pay for, and we have some funding to be able to do that. But again, for us here at the health department, we are on a DART line, and it makes it easy for people to come to us to get vaccinated. And then finally, that access to healthcare. Are there healthcare facilities in the neighborhood, and are they connected to them? There are many people that in a lot of areas, but we see it here in Polk County, that use the emergency room as their primary care location. And so they're really not connected to a primary health care provider. So what are we doing to address this disparity? Here in Polk County, we have had a program. We are training trusted messengers across our refugee and immigrant and African American communities to educate their communities. And we are paying them for this service. So we pay them to translate for us. We pay them to go out and do the work. And we need to have two-way communication with them, not only so that we can share the right health information with them, but we need to know what they're hearing from their community. What are the barriers? What are the concerns? And how can we overcome those? We try to have clinic dates and locations that meet their needs, especially as vaccine uptake is slowing down. We're going to do many more micro clinics where we go to churches, small locations, and things to meet their needs. What are their work schedules? Are you open in the evening? Are you open on Saturdays? I mentioned interpreters at clinics. That's something that's important, and translation of those materials into their languages. I talked about the transportation, a walk-up option. We are a drive-in clinic here at the health department, but we have a lane that if you don't have a car, you can get served. One of the first complaints we had about Test Iowa was that if you didn't have a car, you couldn't go get the free test because they wouldn't take you as a walk-up. So we made sure that when we designed our clinic here at the health department, that wasn't what happened. Minimize your law enforcement presence. Again, it's that fear of, are you going to be here and are you going to pick me up? So we try not to have, we try to have the sheriff or the police department, if we had an issue, close at hand, but not highly visible. And then finally, we're launching an ad campaign that will feature people from their community. They don't want to hear from me. I'm a 62-year-old white woman. You know, they need to hear from somebody in their community. So those are some of the things that we're doing to address the vaccine disparity. So lessons learned. I don't know, it feels funny. I don't feel old enough to be sharing lessons that I've learned throughout my career and my life, but I feel it's a leadership forum and it's important to do so. First of all, I think one of the things I've learned to do throughout my career is to say yes, and to say yes to opportunities and get uncomfortable. In my career at Hy-Vee, I mentioned the 9 Hy-Vee Healthy U-mobiles. They said, we need you to build those. It's like, okay, that seems a little crazy to me, but okay. So learn to say yes. Helen, go out and figure out how to have pharmacists do flu vaccines. Okay, figure it out. And have confidence in your skills to solve those problems. Most of the things that we get handed to us are not problems that have obvious solutions. And so you need to have an ability, a confidence in your ability that you're a smart person to be able to figure this out. And the next point is that you don't do it alone. If I could give everybody on here one big piece of advice is develop your people skills. Nobody does any of this work alone. You do it through people and with other people. And so you need to develop those relationships. You never know when they're going to come back and help you. I have leaned on every relationship that I have had and made in 30 years to bring Polk County safely through the pandemic. I am working with my friends and peers at the Iowa Pharmacy Association. I'm leaning on my peers at Hy-Vee, where I retired from. I am talking to Drake University. I am talking to food pantries and people that I met throughout my Healthy Estate career to bring this community along. So develop those, because my experience is that most of the jobs are people skills, and very few of them are technical skills. I mean, you need both. You need both, but most of your job is going to be, how do you work with people? How do you communicate with people? And how do you, and when I say work through them, how do you get people on board? It's really about coaching. How do you set the direction, set the tone, and get them to believe in your goal and your vision and follow you as you do these things? And that's all because you have to build a trusting relationship. You have to be an honest person. You never know when you're going to need their help and expertise. You have to be humble. You have to be willing to say, I don't know it all, but I know somebody who does. I don't know the answer to this, but I know somebody who does. And be vulnerable. Be able to say, I messed up. That's how you build trust. And then finally, I'm a believer in servant leadership. I always put others first. I tell my staff here that my primary job is to help them to achieve their goals and help them in their development. And when I do that, then I've achieved my career goal and mentoring people. So with that, like I said, a COVID pandemic wasn't exactly in my career plan. It certainly wasn't in my plan when I joined the health department, but it's what life had to hand me. And I used every tool in my toolkit, and I'm still doing it to this day, to try to steer my community safely through this pandemic, as safely as I can. My heart breaks. I've lost over 610 residents of Polk County to COVID. Much of it could have been, preventable to a degree, but we don't give up, and we're charging forward. So with that, I will end and take any questions.
Helen and Sandra, I don't have a question, but I just want to comment. First of all, both presentations were highly informative, but the lasting impression that I will have is the emotion that both of you, that clearly came through in both of your presentations. This was not just a professional message, this was a very personal message. And to me, you just, both of you knocked it out of the park and contributed in incredibly meaningful ways to today's presentation. So I don't have a question, but just simply a heartfelt appreciation for a job exceedingly well done. Turn it back to Lupe so she can lead us in questions.
I just want to make a comment. I mean, Helen, thank you so much for sharing your experience in Iowa. And I think both of us with a public health background just see such an incredible intersect between what Pharmacists does and everything about public health, because, you know, like she mentioned in her presentation, it's not just about the healthcare, but it's everything else that surrounds the patient: access, food, housing, all of that really makes a difference. And we, as some of the most accessible providers, are sometimes, you know, the place that people go to for help with advocacy and to support them. And so I feel like that's just an incredible intersection. And I think both of us in our careers have really leveraged both very successfully.
You know, I said it early on in this, I have been very much someone that knew and believe in the capacity of pharmacists to deliver healthcare to our communities. And I have leaned on pharmacists very heavily in our response. Our vaccine plan never included me. Well, I had to have a plan for it, but never really included me as something I wanted to do, of holding a mass clinic at Wells Fargo Arena. I said, I don't need to do that. I have hundreds of pharmacies across Polk County that are in everybody's neighborhoods that can deliver this vaccine. So if I could ask anything of you on the phone right now, where I need you is to help your patients overcome vaccine hesitancy. Have a conversation with your patients about COVID vaccine and encourage them to get vaccinated. What we are hearing is that we've got our early adopters kind of through the bubble, and that it takes that trusted health professional, which you are one of them, that has a relationship with your patients, to convince those hesitant people that it's safe and it's effective and it's in their best interest, because they trust you. And I need your help in this.
Helen, that was beautiful. I think that is the exact message we all should take from today. And we do have 2 questions for you so far, as I can see. Hannah, go ahead.
Hi everyone, my name is Hannah. I'm a P2 here. My voice is a little shaking now because I know I'm speaking in front of a lot of big leaders. So my question today is for Dr. Helen Eddy. I know that you're working with the Polk County Department, and along the way, I'm sure you've been working with political leaders. So I'm just wondering, what obstacle have you gone through to get to where you want today with the COVID pandemic, and also what tips or I guess skills that you have that helped you gone through the obstacle?
Oh, what a great question. Thank you for that. Very early on, it became apparent to us that there were going to be politics that got woven into a public health response, which is really never helpful. And we took the position that we needed to tell our community the truth and be honest and forthright and direct. And I mean, I can be a wiseacre in my private life, but I really, professionally, it's like, I'm going to tell you the straightforward stuff. And I was always honest. I was not afraid to tell the truth. I never shirked from the truth. And if we did something that we didn't think was quite right, we owned up to it. And we developed, I would say, a reputation here at the health department for being that honest, trusted voice. But I think that comes from, being a healthcare provider. I'm a healthcare provider. I'm a healthcare professional, and I'm not too interested in the politics. My goal is the health of my community. So sometimes I was at odds with the politicians, and you have to be a little brave and be willing to take a little bit of heat for that. But I've tried not to be political. I have tried to be straightforward and honest and share the science and share what we know. And have to tell people, this is what we know so far. It's a pandemic. It's a novel virus. So that information is going to change over time. And when it changes, I'm going to tell you that it changes. So thank you. That's a great question. Did I answer it?
Yes, thank you.
Yeah, certainly. Numbers talk. in pharmacy and public health. Okay, Chrissy, go ahead with your question.
All right, hello, I'm Chrissy Lawson coming to you from Daniel Pharmacy in Fort Dodge. Excited to join today and hear from such wonderful speakers. But I was just wondering if you have had any success or can speak to any kind of strategies you're using to target some of our more transient type vulnerable populations, like people who are experiencing homelessness.
Sure. We're partnering with our local federally qualified health center and with JAPA, which is an outreach community to our homeless populations. And there are camps along the river here in Des Moines, and they are taking J&J vaccine and actually going out to the homeless camps to reach out to them. That effort got put, unfortunately, we've just gotten some of the J&J vaccine into Polk County, and then we had to pause it, but we're back out there doing that. We're also taking the vaccine down to the physical shelters that we have. And again, J&J vaccine is probably well positioned for that with a one shot. We're going to be lucky because of historical trauma and fears to get one vaccination in them, much less 2 doses. So there's some pretty significant outreach. And our role here at the health department is sometimes not to go out and do the work ourselves, but to know who in the community has the capacity and to put those people together and then say go. So that's what we're doing in terms of vaccination. One of the interesting things we did early in the pandemic was trying to figure out how we were going to safely shelter people that were experiencing homelessness while they were in isolation or in quarantine. And so actually Polk County and the Polk County supervisors, we put together a shelter out at the Iowa State Fairgrounds, took over one of the buildings out there, the 4-H youth fairground building, and put that together. But, you know, you learn some interesting things. Once they went in, they couldn't leave, but it was really just a safe place to be. It was fed and they had amenities, but they couldn't leave. And then they felt like maybe it was like COVID jail. And so there's some hesitancy for them to come forward and want to go. So we shut that down after a few months. And now we are putting up people that are experiencing homelessness that need to be in quarantine or isolation in hotel rooms. And that's actually working much better. But we were really fearful that it could get into our shelters and into our those populations and really kind of overwhelm where we could send people. Thank you for the question.
The next question for me will be for Gretchen Brummel. Did that second question answer your question that you have in the chat box, or would you like to expand it on that a little further? Are you still on the call?
Yeah, hi, thank you. I was just curious, I'm coming to, first of all, thank you to both speakers, fantastic job, and coming at you from northern Wisconsin. We've had definitely some challenges here locally, specifically with homebound patients that aren't able to leave their homes. And I'm just wondering if you have any examples of successful approaches for those populations.
What we're doing here in Polk County is that we are actually partnering with, I believe, a University of Iowa College of Pharmacy grad, Casey Villauer, who has started a program called Vaxi Taxi. And we are contracting with Casey here at Polk County to, we pay her to go out and deliver vaccinations to the homebound. We have a call center, so we take in people that self-identify as being homebound. We have a list from our Medicaid MCOs of people that are homebound that haven't been able to be vaccinated, and sometimes people call her directly. So we're identifying and doing that. Our other option would have been to send what we call a strike team out of public health nurses to go directly out and do that. And she's got this program, and we want to support her and thrilled to do so. So that's how we're handling it here in Polk County.
Yeah, I appreciated what you said, Helen, about collaborations, not necessarily having to do the work yourself, but finding out who in your community is doing that. And FQHCs are a great resource. Public health departments, we've been partnering locally here in Pima County with our public health department on a number of different initiatives. And they definitely, if they don't have somebody, they'll connect you to the right person. The other thing I've just been trying to participate in is there's a lot of coalitions that represent different special populations, and they've been having a series of webinars to address specific situations and examples of best practices. So they've had different groups come out and talk about some of the best practices that they've implemented in their community. So I've been learning a lot from those types of presentations and participation in those programs.
Thank you all for those amazing questions. Unfortunately, we are at time for tonight, but I will be sharing here in the group chat the Google form where you are welcome to submit additional questions, and we will send those to the speakers. And again, thank you to the Zada Cooper Leadership Committee for your amazing work in putting this together today. And thank you all for allowing me to be your MC for the day. I hope everyone has an amazing rest of your day. And so we'll see you hopefully soon in person next year.
Thank you for the opportunity. Much appreciated.